Hi guys, this is Dr. Perry again taking you in blood physiology. So today we'll be looking at physiology of blood lecture 5. In this lecture 5 of blood physiology, mainly we are going to discuss destruction of red blood cells. So we have red blood cell destruction. Then we're also going to discuss red blood cell disorders or diseases associated with red blood cells. So there are different types of diseases that are associated with red blood cells. You have polycythemia, where you have an increase in total numbers of red blood cells. Then you have anemia, where you have a decrease in total numbers of red blood cells. When you do your red blood cell count, you'll be able to differentiate the two types of disorders. Those that are associated with an increase in red blood cells and those that will be associated with a decrease. So for the sake of this video, I'm going to split it into two parts so that it becomes a short video. So the first part of the video, we're going to discuss red blood cell destruction, and we're also going to look at polycythemia. In the last part of the video, we're going to discuss different types of anemia. So let's start with red blood cell destruction and the fate of red blood cells. So which organs are involved in the destruction of red blood cell? You know, to say you have the reticular endothelial system that is involved in removing aged red blood cells. These aged red blood cells, if they have lived their lifespan, excuse me, and you know on average that red blood cell will just only live for about 100 to 120 days at most. So 100 to 120 days. So after those days, the red blood cell, they need to be removed from the circulation. So which structures are involved there? But you also need to know that the red blood cells, they don't have the nuclei within them. So they don't have nuclei within them, and then they don't have ribosomes, they don't have RNA. So they are incapable of producing their own proteins. They can't produce their own proteins. So if they can't produce proteins, it means that it's very difficult for this cell to repair themselves. So that's why once they leave their lifespan, they need to be removed from circulation so that you use the products for producing other red blood cells, as I'll be explaining with you. So let's start. But before we go into detail of red blood cell destruction and the fate of red blood cell, you need to understand fragility and hemolysis. What is fragility and hemolysis? So let's start by looking at hemolysis. So we define hemolysis, which is basically the breakdown of red blood cells. Hemolysis is a breakdown of red blood cells and liberation of hemoglobin. So once the red blood cells are broken down, there will be release of hemoglobin, which is a major protein that is found within the red blood cell. This hemoglobin, later on, we'll see the metabolism of hemoglobin that will result into more production of bilirubin, and also part of the globin will be used for protein synthesis, because you know to say that there will be amino acids that will be coming from there. Fragility is susceptibility of red blood cell to hemolysis or tendency to break easily. So the susceptibility of red blood cell to hemolysis or the tendency to break easily is fragility. So there are two different types of fragility. There is osmotic fragility that is due to exposure to hypotonic saline or hypotonic solution, if you want. So when you put red blood cell in hypotonic solution, you expect molecules to move from this solution, the water molecules to move from this solution to the cell. So the cells will be becoming bigger because this is a hypotonic solution. Remember, tonicity, you're looking at the osmolarity of the solution to that of plasma. In hypotonic, the osmolarity of the solution is less as compared to that of plasma. So it means you have more water molecules in this solution. So if you put a cell in there, you expect a net movement of water molecules from the solution into the cell. So the cell will be becoming bigger and bigger, and that will result into the cell becoming more prone to rupture. So they will start rupturing as they're becoming bigger. If they can't sustain that tension that is created, is due to water molecules that are moving via osmosis into the cells. Then you also have mechanical fragility. Mechanical fragility is due to mechanical trauma. So if you traumatize a cell, it can break depending on how much pressure you're applying to that cell. So these are the different types of fragility, which are very important when you're looking at red blood cell destruction, because fragility will reduce with the age of the red blood cell. So if the fragility is reducing due to the age of red blood cells, they are not flexible, and as they are passing through the capillaries, certain capillaries in the spleen, it will result into destruction of these cells, and then that will result into hemolysis. Then there's the reticuloendothelial system that you need to understand. So different organs, they have this reticuloendothelial system, but the major one that is involved in red blood cell destruction is the splenic reticuloendothelial system. So within the spleen, you have the reticuloendothelial system, and this reticuloendothelial system is just a fancy terminology for monocytes, macrophages. So these are macrophages that are involved in hemolysis, destruction of the red blood cell, depending on the age of the red blood cell and the other factors, the shape, the flexibility of the red blood cells. And sometimes if the red blood cells are having antibodies on them attached to the antigens, they can also be phagocytosed by this reticuloendothelial system. So even within the liver, you also have the reticuloendothelial system that is capable of destroying aged red blood cell, even the bone marrow itself. You also have the macrophages in there that are also involved in removing old or damaged red blood cells. So like I said, the spleen is the one that is involved in removing these damaged or aged red blood cells. So blood cells passing through the splenic pulp before entering the sinuses undergo thorough squeezing. So as they are going through the splenic pulp, there are smaller capillaries there, and those capillaries are smaller as compared to the other general capillaries from the other tissues. So because the capillaries that are found within the spleen are smaller, it means that now this is where selection will take place, checking how functional these red blood cells are. So those that are not able to change shape so that they pass through these capillaries, they'll be removed by the reticuloendothelial system. This is where now you receive the blood so that you only remain with the functional red blood cells. So that's why you have such capillaries and the reticuloendothelial system that is involved in the destruction of red blood cell. Therefore, it is be expected that the fragile red blood cells would not withstand the trauma. So therefore, it is to be expected that the fragile red blood cell would not withstand the trauma. So as they are passing there, so those red blood cells that are fragile, they can't withstand that trauma. So they'll end up being destroyed or rupturing. Then that's where now the reticuloendothelial system will come in and remove those blood cells, the damaged blood cells, as they are passing there. For this reason, many of the red blood cells destroyed in the body have their final demise in the spleen. So this is where you have the final demise of red blood cells in the spleen, because it's the one that is going to select the functional red blood cells and dysfunctional red blood cells due to the age and other factors associated with the flexibility of the red blood cells. After the cells rupture, the released hemoglobin in the cell trauma are digested by the reticuloendothelial cells of the spleen, like I've already said. And the products of digestion are mainly reused by the body as nutrients, often for making new blood cells. So that statement is simply just pointing to the fact that after you have hemolysis of these red blood cells, there are certain products that are coming out of hemolysis that can be reused by the cells. And some of them, mainly they are used for producing more red blood cells. For instance, the iron that is coming from the heme group will be recycled for the production of more red blood cells. And the amino acids that are coming from globin, polypeptide chain, can also be reused for more production of hemoglobin later on, and also production of other proteins needed by the body. This slide is just summarizing what we've already discussed, the destruction of red blood cells. So you can see the lifespan of red blood cell is about 120 days, and these cells are metabolic active cells. So with time, find that the old cells, they are more fragile, and the cell membrane is also fragile. So as they are passing through the spleen, they are not capable to withstand that pressure. So if they can't withstand that pressure, then they will rupture. Then the reticuloendothelial system, the macrophages that are found within the liver, the spleen, the bone marrow, will take advantage of that and phagocytose part of these remnants of red blood cells. And that's where you have now liberation of hemoglobin and also the iron that can be reused by other cells or for more production of red blood cells, like I said. So you have the polypeptide, which are amino acids, and these will provide amino acids for protein synthesis. And this protein could be hemoglobin again. Then the iron that is coming from the heme group to be stored within the liver and bone marrow as ferritin. So it will be stored as ferritin, and when iron is required, it will be released and then to be used for more production of red blood cells. So the heme, the porphyrin, the heme or the porphyrin is the one that will be converted into bilirubin, and the bilirubin will be secreted by the liver into the bowel. Okay, but if you have excessive destruction of these red blood cells, the previous lecture, I told you to say it can result into a condition which is called jaundice. So jaundice is as a result of excessive destruction of red blood cells that will result into more production of bilirubin. This bilirubin is yellow in color. That will result into discoloration of the tissue, and then the skin will be yellow, especially in neonates after rhesus incompatibility that I explained. This diagram is just summarizing the whole process of red blood cell destruction, the fate of red blood cell. So I'm just going to explain this diagram for you so that it makes sense. So let's start from here. So here, this is where erythropoiesis is taking place, the process that you know by now. So you have the addition of the iron to the globin for the production of the hemoglobin. Then you also need vitamin B12 or folic acid for maturation of red blood cell. And on top of that, you also need a hormone which is called erythropoietin that is involved in stimulating the cells to differentiate into mature red blood cells. So after erythropoiesis, you have more production of red blood cells, and these red blood cells in the bone marrow will be released now into circulation. So you can see the mature red blood cell that has been released into the circulation from the red bone marrow. Then after 120 days, this is the normal lifespan of red blood cells. So you find that this cell will become dysfunctional, so it needs to be removed from circulation. So this is where the reticuloendothelial system comes in, mainly the reticuloendothelial system of the spleen. So within the spleen, you have this reticuloendothelial system where you find the macrophages in the spleen, the liver, and the bone marrow as well. The red blood cell, they will die now. Why? It's because as they are passing through those tiny red blood, the capillaries of the spleen, you find that there will be damage to the plasma membrane, and then they are not flexible, so they will be damaged, and then it will result into hemolysis. Then after hemolysis, there will be phagocytosis. After phagocytosis, you find that there are components of red blood cell destruction that will be used by the cell. So let's start. So you have the hemoglobin that will be digested into the globin and the heme. The globin, these are polypeptide chains. So after breakdown of the polypeptide chains, you're going to have amino acids. And these amino acids can be reused for protein synthesis. An example of this protein synthesis, it could be another hemoglobin or another protein by another cell. Then you have the heme group. The heme group, you have the conversion of the heme group into biliverdin, the biliverdin, and then the iron part will be released. So the iron part will be stored as ferritin within the liver or other tissues. Then if it's required, it will be transported in circulation by transferrin. This transferrin will transport the iron to the liver. Then the liver is going to convert it into ferritin, like I said. This ferritin, it can be used by the bone marrow for more synthesis of the heme group. So you can see that. But the heme is also converted into biliverdin. The biliverdin will be converted into bilirubin within the macrophage, and the bilirubin will be released into circulation. The liver has got cells that can convert the indirect bilirubin into the direct bilirubin. This reaction is called conjugation reaction. The direct bilirubin will be excreted into bile. So the GIT is involved into the small intestine. So they will be released as part of bile or bile salts into the GIT. Then the GIT, within the intestines, you have bacteria. So the bacteria can work on bilirubin. It will convert this bilirubin into urobilinogen. The urobilinogen, some of it will be converted into stecobilin, and stecobilin will be excreted as part of the fecal material. So you can see this stecobilin that is being released as part of the fecal material. Then some of the urobilinogen will be reabsorbed into the system. Then once it has been reabsorbed, it will be transported by blood to the kidneys. And the kidneys, they have other enzymes that can convert the urobilinogen into urobilin. And the urobilin will be excreted in urine as such. So in the urine, you expect some amount of urobilinogen that is coming from red blood cell destruction. So this is the fate of red blood cell. So red blood cell destruction and the fate of red blood cell. We proceed. So now let's look at red blood cell disorders, starting with polycythemia, like I said. Okay, so let's start with looking at red blood cell disorders. So according to the size of cells, so we already discussed this information, so I'll be a bit fast here. So according to the size of cells, you can have classification of these diseases that are affecting the red blood cell. So the normal size are normal red blood cells. You're looking at the size. The microcytes, these are small size red blood cell. Normal size red blood cell. Microcytes are small size red blood cells. So you're looking at the MCV. Then you have macrocytes. Macrocytes are large size red blood cell. Anisocytes, these are cells of different size. So when you're looking at microscope and then you have cells of different size, that condition is referred to as anisocytes. So for you to tell about this information, you need to calculate the MCV, of which I told you how to calculate the mean corpuscular volume. Under normal circumstances, it has to be between 78 to 90 or 94 femtoliter. So anything below the range, then you are talking of more of microcytic. Above the range is macrocytic. So that we discussed. Then according to the color, you can have, we are looking at chromia. So the color mainly is referred to as chromia. So you can have normochromia, hyperchromia, or hypochromia. Normochromia, normal colored red blood cells. Hypochromia, these are darker due to increased hemoglobin. So if you have an increase in hemoglobin, that condition is referred to as hyperchromia because they will be darker, these cells, due to the increased concentration of hemoglobin. Hypochromia, they will be pale due to decreased hemoglobin content, and you can calculate this using MCH and MCHC, the mean corpuscular hemoglobin and the mean corpuscular hemoglobin concentration. So these were already discussed. So some of these red blood cell disorders, they are classified based on the size of the cells and also the color of the cells. So anemia, we'll discuss it later on, but just looking at the general classification of anemia, anemia can be classified by looking at the morphology of the cells. So you have morphological classification of anemia by looking at the size of the cells, whether they are big, small, or normal size. Normocytic, microcytic, and macrocytic, like I've already explained from the previous slide. Then you can also classify anemia based on etiology. So etiological classification of anemia, the cause of anemia. So you can classify it depending on the cause of anemia, the etiology. Polycythemia, So you have an increase in the number of red blood cells. Anemia is the decrease. Polycythemia is an increase in the number of red blood cells. So you have polycythemia vera, relative polycythemia, and secondary polycythemia. So in this part of the video, this is where I'm going to explain the polycythemia. The polycythemia vera, the relative polycythemia, and the secondary polycythemia. So I have the primary and the secondary polycythemia. So I'm going to discuss this. So the polycythemia vera is also referred to as the primary polycythemia. So I have different types of polycythemia. So in general, polycythemia is an increase in the red blood cells. Sometimes it's also referred to as erythrocytosis. Erythrocytosis. Erythrocytosis is an increase, it's a condition with an increase in the circulating red blood cells characterized by increased hemoglobin level. So the concentration of hemoglobin is going to increase, and also the number of red blood cells is also going to increase. So you expect that the total red blood cell count is going to increase, and also the hematocrit is going to increase. So there are two types of polycythemia. So you have relative and absolute. These are just the general types of polycythemia. You can have a relative polycythemia and absolute polycythemia. The relative polycythemia occurs as a result of loss of fluid with hemoconcentration of cells. So for some reason, maybe you're losing plasma, but you're not losing red blood cells. That can result into a relative polycythemia. So it's relative to the amount of blood cells with regard to the volume of red blood cells or volume of blood in general. So it's relative to the volume of blood. So if you're losing fluids, maybe you're vomiting or you have diarrhea, what you're losing there are electrolytes and also the fluids. Because you're losing electrolytes in the fluids, you're not losing the red blood cells. The concentration of red blood cells will increase because the total blood volume will reduce, but number of red blood cells are not reducing. So the concentration of red blood cells is going to increase. So in that case, you're going to have a relative polycythemia. She is mainly seen in vomiting, diarrhea, and when you have loss of electrolytes. The absolute erythrocytosis is divided into primary and secondary. So this absolute is the one now that you can have the effect of maybe cancer that is affecting the bone marrow or other conditions that can affect the production of erythropoietin. So that will have an effect on the production of red blood cells. So let's start looking at primary polycythemia. What happens in primary polycythemia? So the primary polycythemia is the true idiopathic increase in the number of circulating red blood cells and of the hemoglobin level. So you have an increase in the number of red blood cells and also the hemoglobin level. But this increase in the red blood cell is not well understood. But what we know is that there are certain mutations that can take place within the bone marrow. And these mutations will result into abnormal production of red blood cell. So the bone marrow with an inherited increase in proliferative activity. So it means that the bone marrow will be hyperactivity of the bone marrow that will result into an increase in the proliferative activity of this bone marrow. They'll be producing a lot of red blood cells. So the mutation in most cases is associated with the signal transducers. You know to say that when you have erythropoietin needs to go and bind to the erythropoietin receptors to cause differentiation of those committed cells to become a particular mature red blood cell. You remember the stages of erythropoiesis. So in polycythemia, the primary polycythemia or polycythemia vera is whereby you have a mutation in the proteins, and these proteins are called the JAK and STAT proteins. The JAK, these are Janus kinase 2 proteins, and the STAT proteins are signal transducers and activator of transcription. So when you have mutation of these proteins, even if erythropoietin is not attaching to them, it can stimulate the hematopoietic stem cell to differentiate into more of the red blood cells. So you find that you have an increase in the production of red blood cell in absence of erythropoietin. So this is the primary polycythemia. Then you also have secondary polycythemia with the known etiology. So the cause is known here. So in the secondary, the cause is known, but in primary polycythemia, the cause is not known, but there is just hyperactivity of the bone marrow that will result into more production of red blood cells. In secondary polycythemia, with a known etiology, there is absolute increase in red blood cell mass, resultant to enhanced stimulation of red blood cell production. So here you have enhanced production of red blood cells as a result of diseases that are affecting the production of erythropoietin in general. Erythropoietin is coming from the kidneys, about 85%, 15% is coming from the liver. So there are certain diseases that will result into more production of erythropoietin that will stimulate now the hematopoietic stem cell to differentiate into red blood cells. So this secondary polycythemia is as a result of another disease that is stimulating the factors that can stimulate erythropoiesis. For instance, you have bone marrow anoxia. Anoxia is the extreme or severe case of hypoxia. In case of pulmonary dysfunction, high altitude, then carbon monoxide poisoning. So because of these factors, when you have pulmonary dysfunction, it means there is no adequate gaseous exchange that will result into hypoxia, and then there will be more production of erythropoietin, as we discussed. High altitude, the higher you go, the less oxygen, and that can also predispose you to hypoxia, and later on it can become anoxia. So you find that the cells that are responsible for the production of erythropoietin will be stimulated by these factors. Then the end result, they will stimulate more production of red blood cells. So it's secondary polycythemia, secondary to something else that is happening within the body. So you can see the production of an erythropoietic stimulating factor is increasing. So sometimes you can have drugs that can stimulate the production of erythropoietin, or chemicals such as coal, mercury, iron, just to mention a few. So there are certain chemicals or drugs that can also stimulate the production of erythropoietin. Because erythropoietin is being stimulated, its quantity will increase, and then it will overstimulate the bone marrow. Not that the bone marrow is producing more red blood cells, but because of the presence of more stimulatory factors like erythropoietin, then it will produce more red blood cells. So that's the secondary polycythemia. So an example of primary polycythemia, like I said, you have polycythemia vera. So this polycythemia vera is an example of primary polycythemia. So what happens in polycythemia vera? So you have chronic stem cell disorder. So this polycythemia vera is a chronic stem cell disorder with an insidious onset characterized as pan-hyperplastic and malignant neoplastic marrow disorder. So meaning that you have pan-hyperplastic, malignant, neoplastic marrow disorder. It's affecting the bone marrow itself. That's why it's an example of the primary polycythemia. So for some reason, you have maybe a tumor that is developing within the bone marrow, and then this tumor is stimulating more hematopoietic stem cell to differentiate into red blood cells. So you have an increase in the production of red blood cells. So if you have an increase in the production of more red blood cell, then you have polycythemia. So there will be an absolute increase in the number of circulating red blood cells in the total blood volume because of uncontrolled red blood cell production. So this production of red blood cell is not controlled. It's not sensing the presence of erythropoietin. Erythropoietin is not the one that is stimulating them. So there's just hyperactivity of the bone marrow that will result into more production of red blood cells. So because the bone marrow is hyperactive, the bone marrow is not just producing red blood cells, there are also white blood cells and platelets that are being produced there. So you find that polycythemia vera will be accompanied by an increase in white blood cells and platelets, because the hematopoietic stem cell is the one that is being stimulated, or there is mutation in the gene within the hematopoietic stem cell that will differentiate into red blood cell, that will result into an increase in red blood cell count. Then it can also differentiate into white blood cells that will result into an increase in white blood cells. And also it can differentiate into megakaryocytes that will now give rise to platelets. So there will also be an increase in the production of platelets. What are some of the clinical manifestations of polycythemia vera? So in some patients, they will be asymptomatic, meaning that they won't show any clinical signs, so they are asymptomatic. But sometimes you can see, okay, so these are clinical signs. So you have pruritus. This pruritus is just the irritating of the skin. So you have uncomfortable, irritating skin. So the skin becomes itchy. So you're scratching a lot. That can also result into inflammation. And then the other clinical sign is vertigo. Vertigo is just whereby somebody feels like you're spinning. So that spinning sensation is called vertigo as a result of an increase in red blood cells. Then you have gastrointestinal pain, headaches, paresthesia, fatigue, weakness, paresthesia. This is just like you feel like somebody's pricking you with needles and pins. So that sensation of needles and pins, like somebody's pricking you, is called paresthesia. Then there's visual disturbance, tinnitus. Tinnitus is just the sensation whereby you feel like something is ringing, but there is no actual sound. There is no stimuli for noise, but you are getting some noise because of polycythemia. So these are some of the clinical signs. So bear in mind that you will discuss these conditions in pathology in detail. So I don't want to waste much time because I'm just pointing out what you can appreciate in physiology. Why should you have these signs? Then you also have oral manifestations of polycythemia vera. So the oral manifestation of polycythemia vera, you're going to find erythema. Erythema is just red, purple color of the mucosa. Glossitis is the inflammation of the tongue. So you can see here some of the clinical signs. You have glossitis, inflammation of the tongue, erythematous or edematous gingiva. So you can see inflammation of the gingiva. So you have spontaneous gingiva bleeding because of bleeding disorders that is also associated with polycythemia. The laboratory findings, you can guess this because there will be normochromic, normocytic. There will be normochromic because the red blood cells, they are differentiating and then they're becoming mature before they are released. So there will be normocytic in terms of size. And then there's normal concentration of hemoglobin or the content of hemoglobin. So there will be normochromic. So you have an increase in normochromic, normocytic red blood cells. So the normal amount of red blood cells that a normal person should have depends whether you're male or female. Males, they have more. On average, 5 millions of red blood cells per cubic millimeter of blood. But here you have an increase, more than 10 million red blood cells per cubic millimeter of blood. That's an increase, hence the name polycythemia. Then the hemoglobin content will also be increased, greater than 20. Platelets will increase. The normal number of platelets should be 150 to 400,000, but here you have 400 to 800 platelets per deciliter of blood. Then the bone marrow will be hypercellular, megakaryocytes are increased. So meaning that to be hypercellular, you have a lot of those hematopoietic stem cells. There's a lot of activity that is resulting into the polycythemia. What would be some of the treatments?
So there's phlebotomy. Phlebotomy simply means removing of blood using a vein. So you can aspirate some of the blood because there is overproduction of blood. So you can remove some of the blood from the vein. And there are also drugs that you can use, chemotherapy. You can also use radioactive phosphorus. So these are some of the treatment that you can use. So for this video, I'm going to end here. Then the part 2, that's where we're going to discuss anemia.